My name is Mia and I'm a second year nursing student. Today I'll be discussing emphysema, a chronic lung condition under chronic obstructive pulmonary disease or COPD. It is important for nurses to understand because of the prevalence in Australia and the significant impact on patient quality of life and health services. In this presentation, I'll cover the epidemiology, pathophysiology, pharmacology, and acute care planning, drawing on the case of Michael Roberts, a 60-year-old retired construction worker diagnosed with emphysema. This discussion aims to provide graduate and enrolled nurses with knowledge to support safe and effective patient care. Emphysema, as part of a chronic obstructive pulmonary disease or COPD, is a major public health issue in Australia. According to the Australian Institute of Health and Welfare, around 638,000 people, or 2.5% of people in Australia, were estimated to be living with COPD in 2022. Emphysema specifically is strongly linked to smoking, which accounts for the majority of cases, as well as occupational exposures such as long-term exposure to dust and chemicals in industries like construction, which makes up 20 to 30% of COPD. National data shows that adults who smoke daily are significantly more likely to have COPD compared with ex-smokers or those who have never smoked before. While smoking remains the primary risk factor, occupational exposures, like I said, are also critical. And this is particularly relevant to Michael Roberts, who has a history of construction work, placing him at a higher risk. In terms of burden of disease, COPD is the fifth leading cause of death in Australia, with emphysema contributing significantly to mortality and morbidity. It is also a leading cause of potentially preventable hospitalizations, which highlights the gaps in both primary prevention and chronic disease management. Hospital admission rates are consistently higher in men than in women, and Aboriginal and Torres Strait Islander peoples are disproportionately affected, with prevalence rates of almost twice as high compared to non-Indigenous Australians. Among adults aged 45 years and older, COPD accounts for the majority of respiratory disease burden, making up around 65% of the total. This is particularly significant for nursing practice, as it highlights the need for culturally safe care and tailored health promotion strategies. In 2020 to 2021, an estimated $831.6 million was spent on the treatment and management of COPD, representing a significant proportion of all respiratory healthcare costs in Australia. COPD therefore contributes to a considerable economic burden through hospitalizations, medication costs, and reduced workforce participation, further emphasizing the importance of effective nursing interventions. The implications of these data for nursing practice are profound. Nurses play a critical role in prevention by supporting smoking cessation programs and conducting risk assessments and providing health education. In acute care, nurses are central to recognizing early signs of exacerbation, administering oxygen therapy safely, and delivering evidence-based pharmacological and non-pharmacological interventions. In the community, nurses contribute to long-term disease management through patient education and monitoring inhaler technique, coordinating multidisciplinary care and promoting strategies that improve quality of life. Let's step back and look at what's happening in Michael's lungs. The lungs are made up of branching air passages that end in tiny air sacs called alveoli. These alveoli are surrounded by capillaries where oxygen is absorbed into the blood and carbon dioxide is removed in exhaled air. Emphysema is a long-term lung condition that gradually damages these alveoli, and irritants like cigarette smoke or construction work trigger chronic inflammation. Immune cells release enzymes that overpower protective mechanisms such as alpha-1 antitrypsin, breaking down the alveolar walls and surrounding capillaries. As this damage continues, the lungs lose their elasticity, and instead of many small alveoli, large floppy air sacs form. This reduces the surface area for gas exchange and traps air in the lungs, causing hyperinflation and the barrel chest appearance, often seen in advanced cases. With less effective gas exchange, oxygen levels drop, carbon dioxide builds up, and symptoms like breathlessness, wheezing, fatigue, and prolonged expiration develop. During acute exacerbations, things worsen. Inflammation increases, airways swell, mucus production rises, and bronchoconstriction narrows the already compromised passages. Clinically, this leads to worsening dyspnea, tachypnea, anxiety, and hypoxemia. Over time, the chronic strain on the lungs also affect the heart, leading to pulmonary hypertension. Our frontline medication is salbutamol, or Ventolin, a short-acting beta-2 agonist, which binds to the beta-2 receptors in the airway smooth muscle. activating the sympathetic pathway and causing bronchodilation. This provides rapid relief of acute symptoms like wheeze and shortness of breath, usually within minutes, and lasting 3 to 5 hours. However, salbutamol does not reverse alveolar damage. It only relieves bronchoconstriction. It must therefore be part of a broader plan, including long-acting bronchodilators, corticosteroids, pulmonary rehabilitation, and smoking cessation. From a nursing's perspective, there are several key responsibilities. First, we need to monitor for side effects, which can include tremor, palpitations, and headache. Second, we must ensure patients are using their inhalers correctly. Many patients struggle with timing their inhalation with occultation, so providing education and encouraging the use of a spacer device is vital. Using a salbutamol inhaler with a spacer makes it easier to use and helps to get the medicine into your lungs with less medicine ending up in your mouth and throat. For Michael, reinforcing correct inhaler technique will maximize the delivery of medication to the lungs and improve system control. Now let's consider an acute exacerbation of emphysema in Michael's case. The key acute issue is impaired gas exchange caused by airway obstruction, mucus hypersecretion, and alveolar destruction. Our nursing goal is to help Michael maintain oxygen saturations at or above 92% or at his documented baseline within 2 hours of intervention. The first intervention is to administer oxygen therapy as prescribed. Titrated carefully to the target range. Patients with advanced emphysema are at risk of retaining carbon dioxide if given high flow oxygen. By keeping saturations between 88 to 92%, we optimize oxygen delivery while reducing the risk of oxygen-induced hypercapnia. Second, we administer salbutamol via a spacer and monitor his response. Salbutamol, a short-acting beta-2 agonist, works within minutes and relaxes the airway muscles and improves airflow. This provides rapid relief of dyspnea and the wheeze, but we must also monitor for side effects such as tachycardia, palpitations, or tremors. Third, we position Michael in an upright position and coach him in pursed lip breathing. This simple but effective technique prolongs exhalation, reduces air trapping, and makes breathing feel easier. Upright positioning also maximizes lung expansion and reduces the workload on the diaphragm. Together, these interventions are directly grounded in pathophysiology of emphysema. Oxygen therapy supports gas exchange, salbutamol relieves bronchoconstriction, and positioning with breathing technique reduces hyperinflation. Nurses play a critical role in recognizing early signs, implementing these strategies, and evaluating their effectiveness to ensure safe and evidence-based care. To conclude, emphysema is a key contributor to COPD in Australia, driven by smoking and occupational exposures. Salbutamol provides fast relief, but long-term care is essential. Nurses are essential to prevention and acute management. Thank you for listening, and here are my references.